This talk is on perioperative management and critical care, in particular cases that are relevant to us here at Aintree and the specialties that we deal with. So we have a lot of tertiary surgery that happens here, in particular vascular, maxillofacial surgery and ENT surgery, all both under the bracket of sort of head and neck and major head and neck complex surgery. We also have a fair amount of emergency surgery that goes on, whether that's patient immediately coming post-op as a sort of planned emergency admission, or patients admitted from the ward with complications after this surgery. And common specialties that admit to us in this situation is obviously vascular, emergency general surgery. Trauma keeps us very busy. We do take emergency maxillofacial and ENT patients from the region, and occasionally we get some urology and some interventional radiology patients as well. So vascular patients that come to us electively will be all AAAs, whether that's open or EVAR, but less so EVAR these days. The simple ones actually may not require critical care admission, but the complex ones, in particular the thoracic endovascular aneurysm repairs, will come to us. Anything complicated of any sort will come to us, and there is a certain workload associated with carotid endarterectomies because of their blood pressure fluctuations, and so it's reasonably common that patients following carotid endarterectomy will be on a bit of metronidazole and will need to come to us. They won't tend to be booked electively. It will tend to be an emergency referral, usually about 5 o'clock in the afternoon, when they're still in recovery on metronidazole. And there doesn't seem to be any way to predict who will need this and who won't. And then emergency surgery from vascular, any kind of ruptured AAA will need to come to us. Any complex prolonged revascularization, often these cases are very long and the patients will require vasopressors post-op to meet their blood pressure targets. And occasionally limb amputations, in particular the above knee amputations that can turn into quite major surgery, may well be referred to us. The simple below knees often will be fine going back to the ward. And there is various scoring systems out there that may classify a patient as high risk or urgent. For example, a AAA that's at risk of rupture based on the rate of growth and the size. And our hybrid theatre has opened in 2023, which is in C Theatres, which is right next door to critical care, and that is where all the vascular surgery will be taking place from now on. In terms of MaxFax, all free flap surgery will come to us as a planned post-op admission. These are usually level 2 admissions. Even if they have a tracheostomy, often they'll come and just be managed as a level 2 because they will be breathing spontaneously, often just on a trachea mask. And then emergency-wise, we get all sorts. Any kind of flap failure that returns to theatre will tend to come to us post-operatively. Anything involving the airway obviously will also come to us. So useful things for all surgical patients. Well, the admission is the same as admission for any other type of patient, really. The PENS medical admission form needs to be completed. Their drug chart will need to be reviewed in terms of what usual meds they should continue and which ones they shouldn't. So if this is an admission straight from theatre, they won't have an electronic prescribing prescription. So that will need to be, the medication history will need to be found elsewhere. And then things like their PCA or epidural, if applicable, will need to be prescribed on a separate chart. And any maintenance fluids, etc., will also need to be prescribed on the fluid chart. It's very useful to look at the anaesthetic chart and the op note to see what exactly they've had done, what blood loss they had, what kind of fluid they've received, if they had any blood products, and also in particular the timing of drugs they've received. So for example, the time of antibiotics, if they need to continue, the time they've received them in theatre will help decide the time they next receive them on the unit, and very importantly the time they last had paracetamol to avoid inadvertently giving too much when they get here. Local anaesthesia usage, so there's a number of things there. They may have a local anaesthetic infusion catheter in place, which will need to be set up and started, or they may have had local anaesthetic infiltrated into the wound, so we need to bear in mind the total dose they've had. There's also a relatively new type of local anaesthetic that can be used, which is liposomal bupivacaine. The brand name is Exparel, and this is used for patients who would ideally have a local anaesthetic infusion catheter but can't for whatever reason. And in theory, this bupivacaine that they instill around the wound should last for 96 hours. So it may be that they've done a block with that, or it may be that it's been infiltrated more locally. And importantly with that is that it means we can't use any other type of local anaesthetic for 96 hours. So this should be reflected on the drug chart, and the patient should have a wristband to show that they've received it. There's more information about this on the clinician induction page on the intranet. And what lines they have is important to note. So commonly, a lot of them, the post-op electives we admit, will not have central lines, but they should have arterial lines. And it's important to note if they have any physiological parameters stated. For most patients, this will just be as standard physiological parameters, but for vascular, they may well have a higher MAP target. So the general plan, once they get to the unit, is they will have some ICU admission bloods and a blood gas sent. If they've had a massive transfusion or there's been any issues with bleeding, it's important to send a ROTEM as well and see if they need any further products. Review their analgesia requirements and make sure they've got some analgesia prescribed, and look carefully in the op note for things like when they can eat or when we can start NG feed, and if there's any specific instruction about anticoagulation or VTE prophylaxis. Almost all of our post-op patients will get prophylactic low molecular weight heparin 6 hours post-operatively, or at 10 o'clock that night, whichever is the most sensible timing, if there's no bleeding and the admission bloods are okay. There may be occasions where it's stated in the op note that this is not desired and they shouldn't receive it. If there's any plan for post-op antiplatelets, in particular the vascular surgery patients, often they will just continue them. And again, any deviation from our usual physiological parameters, for example, higher vascular MAP targets, often they would target a MAP of 80 or higher. Antibiotics-wise, look carefully at the indication for antibiotics. In truly elective surgery, it would be very unusual for a patient to be on post-op antibiotics. They would have a dose of antibiotics induction to reduce the risk of surgical site infection, but to continue them post-op is often not necessary. In emergency surgery, in particular, things like infected vascular surgery where they've had an amputation, or emergency general surgery where they've got fecal peritonitis, it often will be appropriate to continue these antibiotics. But it's important to make sure that cultures are sent if they're needed, and that the antibiotics are prescribed correctly. Think carefully about the maintenance fluids. So we would usually use 1 ml per kilo per hour up to sort of 80 mils an hour as a maximum. Occasionally we'd use more for vascular patients, particularly the AAAs, but this would be on a case-by-case basis. And think sensibly. If the patient's likely to require multiple fluid boluses, it might be sensible to run Plasma-Lyte as the maintenance, purely to reduce nursing workload, because in order to deliver a bolus, then all they have to do is program the pump to deliver a bolus. If this is unlikely, then we can use dexaline with or without potassium. And above all, if you're unsure, ask for help and someone will tell you what to do. Other bits, well, VT prophylaxis, almost everyone gets this post-op. It is weight dependent, which we'll cover in the prescribing talk. And we tend to give it 6 hours post-op, assuming they're not bleeding or coagulopathic, assuming this doesn't take them to some crazy time. Like, for example, the surgery's in the morning and we end up giving it in the middle of the day. The day after, we tend to give it at 6 p.m. on ITU. If VT prophylaxis is contraindicated, then the patient must have mechanical prophylaxis, and we use the Flowtron boots, the pneumatic compression devices. And also, if they're going on a heparin infusion, particularly the vascular patients, obviously they don't need VT prophylaxis. Gastroprophylaxis, so by this I mean a PPI, so we would use lansoprazole 30 milligrams for those that can have enteral intake, or pantoprazole 40 milligrams for those that have to have it IV. And for a low risk patient who's awake, not ventilated, and has enteral intake with no other risk factors like steroids or antiplatelets, this isn't required. But for others it is. And then also just think carefully about the risk of withdrawal. So in particular alcohol, where withdrawal can be very dangerous, and nicotine, where withdrawal can be unpleasant. So they may require a nicotine patch. So MaxVax specifics. Well, the analgesia requirements can range massively depending on what they've had done. Typically, the actual site of surgery, as in the oropharynx, for example, isn't the painful bit. Often it's, if they've had a free flap, often it's the bit they've taken the flap from that hurts. So it'd be the scapula, a radial flap, or the thigh, and often that's the painful bit. So we'd usually give regular paracetamol and some regular enteral opiate, usually a short-acting opiate like Oromorph or oxycodone, with some PRNs prescribed. But it's important that if you're prescribing enteral opiates, that the NG position is confirmed via chest x-ray first. The flap obs are done hourly, and this is usually done by one of the maxillofacial doctors that has to come to the unit every hour to check the flap perfusion. And it's important to have humidified oxygen. So they would usually get this via trachea mask, and it's very helpful for our flow through the unit if they are weaned down to wall flow. So by this I mean less than 15 litres high flow, because that means that they're suitable for a ward discharge. And for most patients this won't be a problem. If a patient needs metaraminol, think carefully about their volume status. We have to be careful with a free flap when using vasopressors, because the last thing they want is intense vasoconstriction in that free bed of tissue that's trying to establish a blood supply. So if we're worried about the patient's cardiovascular status, it's worth letting them know so that they can keep a close eye on the flap. NG position has to be checked with a chest x-ray. We tend not to feed in the first night, we tend to keep them nil by mouth in the first night in case they need to go back to theatre all of a sudden if the flap fails. They can have medications, but we tend not to start the feed. We tend to just use maintenance fluids. And often the NG tube position is quite complicated, so it will be stitched into place. There may on occasion be other things inside attached to the NG tube, like salivary tubes. So as a general rule, we shouldn't be touching the tubes. We shouldn't be blindly advancing them or fiddling with them, because we don't know what they're attached to. So if the NG position isn't right, we need to speak to the surgical team to come and adjust that. Vascular specifics, so the levels of care will vary depending on what it is. A ruptured AAA will often come as a level 3. Almost always will come as a level 3. A ruptured AAA that's done as an EVAR often are much less sick, and they may well come as a level 2. An elective AAA will depend on where the site of the clamp is and how complex the operation is. So for a supraceliac clamp, they will always come as a level 3, and then we will tend to wake them up slowly that evening if they have once they've had a period of stability. If it's a lower clamp, they would tend to be extubated at the end and come as a level 2. But obviously in the setting of massive hemodynamic instability or massive bleeding, they may well decide to keep them asleep. Analgesia depends on what they've had done. If it's an open surgery, they will usually have some form of local anaesthetic infusion catheter, and this depends on the site of the incision. So for a typical AAA where they've had a midline laparotomy, they will usually have a rectus sheath catheter. If they've done a retroperitoneal approach and the incision is lateral, they may well have an erector spinae catheter, or even on occasion a paravertebral catheter, though these are less common. And they will usually have a PCA. Epidurals are becoming increasingly uncommon. The analgesia for revascularization depends on the incision site and the procedure. Often the incisions aren't that massive and they'll just have local anaesthetic infiltrated into the wound. And then for carotid endarterectomies and amputations, again, this depends. For carotid endarterectomies, they tend to just have local anaesthetic infiltrated into the wound. For an amputation, this depends on the state of the patient and the level of chronic pain associated with that. They may well have a local anaesthetic infusion catheter going near the sciatic nerve, for example. Otherwise, it would just be standard analgesia such as regular paracetamol and opiates. What can be very useful for amputations is neuropathic adjuncts like gabapentin or pregabalin. Fluids. These patients, especially the AAAs, do have very large fluid shift and they often have very high post-op fluid requirements. And the vogue amongst the vascular team is to run these patients on the wetter side to help perfusion. So often they will have much higher fluid rates for maintenance. A very high clamped aorta may well have maintenance fluid requirements of 125 to 250 mils an hour. Generally we target an HB over 90, although the HB target will often be dependent on the patient and the clinical course. They are very likely to have a different MAP target to our standard 65, so it's important to look for this within the documentations, or ideally be told this face-to-face during handover from the vascular team. Often it would be 80, sometimes higher. In particular for carotid endarterectomies, they may well have a higher MAP target depending on their starting blood pressure. And then the carotid endarterectomies also have neuroobs to check that they've got no developing signs of stroke. Almost all these patients will be on antiplatelets and statins, and generally these will continue post-op, even clopidogrel. And in terms of anticoagulation, it's important to check the op note from the surgeons. All patients should have prophylactic low molecular weight heparin as a minimum, unless there's been an issue, such as bleeding or massive transfusion or coagulopathy, that means they can't. Heparin infusions are increasingly uncommon, but if they're wanted, this should be explicitly stated.